I am so thrilled to introduce our speaker today. So Dr. Jaymin Upadhyay is the Assistant Professor of Anesthesia at the Harvard Medical School. He's also affiliated with Boston Children's Hospital. And Dr. Upadhyay is a translational medicine scientist with a focus on understanding pathological processes and symptoms. So pain and depression and diseases impacting musculoskeletal systems. Dr. Upadhyay has implemented imaging techniques to characterize skeletal disease activity. And much of his work has involved musculoskeletal conditions affecting large populations like juvenile arthritis, but he has also led several projects that investigate ultra-rare conditions, including fibrodysplasia ossificans progressiva. So I'm going to stop my screen and hand it over to you today to begin your presentation, Dr. Upadhyay.
No problem. Thank you. All right. Maybe minimize this somehow, right? Okay. All right, good. I am in full screen mode, so if you do have a question or you want to stop me anytime, just please speak up or type something into the chat room and I'll try to respond that way. Thanks, Hope, so much for inviting me to give this presentation, and also for helping myself and my lab conduct a number of studies in FOP in the last 2-3 years, and that's what we'll be talking about today. So, maybe many of you aren't aware of our lab or what we do, and or me as an investigator in the FOP fields. I just thought I'd give you a very brief introduction on that. So I started getting involved in FOP research back when I was a member at Regeneron Pharmaceuticals. And so my role in the FOP studies occurring at Regeneron was to validate certain techniques such as PET-CT and MRI and determine how we could use them to understand not only the disease trajectory in FOP, but also to see how methods such as PET-CT or MRI can be used to elucidate treatment effect, specifically garetosmab, which is now in clinical trials. And then after my time at Regeneron, I think it was right around 2018, I decided to come back into academia, and so I could do things like work more closely with patients. And since I came back into academia, I've remained involved, and my lab has been involved pretty heavily in FOP research. And we focus so much on not only understanding pain in FOP or the experience of pain in FOP, but also in parallel, developing techniques that enable us to understand the musculoskeletal pathology in FOP patients, as well as the pain from a clinical perspective. So early on, I think it was end of 2017 or 2018, I had the opportunity to be part of an FOP patient forum. And this was my first kind of interaction with the community and patients themselves. And what was really surprising to me from this discussion, from this forum, and I'm a pain researcher by training, and this was some of what came up during this patient forum. That was not only interesting but a little bit unexpected. But what I heard was that so many of the patients, so many of the families said that it was their pain that was causing them so much discomfort, causing them so much kind of loss of quality of life. And while some people did in fact talk about their heterotopic ossification, it was really the pain that was at the forefront of the discussion. And so some of what I heard was, I can't relieve my pain even with the use of strong opioids or NSAIDs. Not only is pain debilitating and severe, but it's location dependent. It's there when I have a flare-up, but sometimes when I don't have a flare-up, I also experience a lot of pain. When I do have flare-ups, not only do I experience pain, but I have a lot of anxiety and depression and psychological stress, and I feel very worried. And so the this latter component here, that feeling anxiety, having a depressed mood, they can, of course, worsen the amount of pain that someone experiences. So with information from this patient form in hand, I thought to myself, well, maybe what's present in FOP is a chronic pain phenotype, and pain that's there that's not only associated with flare-up, but also non-flare-up state. So how can we go about proving it? So the first thing we did was I reached out to the folks at IFOPA, and I kind of told them about what I wanted to do in terms of just having a more fundamental understanding about the pain experienced by FOP patients. And so what they suggested I do is maybe interrogate and look into the FOP registry that many of you may have been part of and participated in. And so this patient registry at the time was about 100 patients who were followed or who completed a series of questionnaires for several months, I believe maybe 2 years or so. And so the first thing we did was we took the pain ratings that the patients in the registry had, and we divided the patients into two groups. Those experience no to mild levels of pain, so from 0 to about 3. And then those individuals, those FOP patients that experience pain between 4 to 10, where 10 is the maximum amount of pain. And what we found was that there were a substantial percentage of patients from the time of enrollment of the FOP patient registry all the way out to 30 months who reported a moderate to severe pain. So what you see here in blue, in this blue trajectory, are the percentage of people in the non-flare-up state who experience moderate to severe levels of pain, or 4 or more on a 0 to 10 scale. And then, of course, there are the individuals who reported pain and or who reported flare-up. And those individuals, of course, had high levels of pain from enrollment to 30 months. So that was the first kind of inclination I had, that, okay, pain is associated with flare-up and FOP, but also it can be there without flare-up. Other analyses that we did was we looked at the relationship between pain and emotional health. And so those individuals who reported pain of 4 or more reported more emotional problems, such as depression, psychological stress, or anxiety. And we also looked at the relationship between pain and physical health. And so, the individuals who reported pain on 4 or more reported also poor physical health. So that was a little bit of an expected finding. And this is what we published back in 2019. So what causes pain in FOP? Well, it can be many factors in the periphery, right? You can have nerve or spinal cord compression, right? That causes pain. You can have vertebral deformities. You can have soft tissue edema or inflammation that causes pain. You can have peripheral neuropathy. So these are all factors, different factors happening from the neck down that can contribute to pain. And we see these factors not only in FOP, but also other rare musculoskeletal or rare bone diseases, such as osteogenesis imperfecta or even fibrous dysplasia. But what's important to keep in mind is that everything that happens in the periphery, at the end of the day, it's going to get registered in the brain, right? So it all kind of comes together in the brain. And that's something that maybe a lot of people who don't do pain research and who aren't well associated with pain and processing, that's maybe something that's not appreciated. So when you think of pain, really think of it as a top of the head to bottom of the feet type of process. And in a similar manner, when we think about emotions such as anxiety, shame, fear, sadness, those we kind of think about as central processes, things that are happening in our mind. But we use a special tool called Embody in our lab. And we ask patients and different individuals to tell us, where in their body do they experience things like anxiety, shame, fear, anger, depression. And as you can see, it's a whole body experience, right? So something that is emotional, something that is mental, it not only takes over our minds, but it also takes over our entire bodies. And that's important to consider for pain as well, because again, it's a mind-body integrative type process. In a later study that we did, we followed 17 patients with FOP, and this was work done with the help of IFOPA again. But what I wanted to do is just understand the dynamics of pain, between baseline and a 2 to 3 week follow-up period. And what you can see is that pain is a dynamic process in FOP, right? Maybe one day you feel no pain, but then just 2 weeks or 3 weeks later, you can experience, moderate to very severe levels of pain. The causes of that change in pain between 2 different time points, even if it's between just 2 to 3 weeks, can be, multiple, right? It could be something happening in the periphery, but maybe there's something that happened that made you feel more anxious. And so that can elevate your pain. So again, pain in FOP, if you take one thing away from this presentation, is that it is an entire whole body process or experience. It's not something that just resides in your brain. It's not something that just resides in the periphery or in your extremities or in your torso. It takes over all of you. In that same study, what we then did was we prospectively evaluated how pain integrates with other symptoms, in this case, depression. And what you can see is that the higher the amount of pain that a person reports, and this is data from about 15 or 17 FOP patients, the more depression that they experience. The more kind of pain that a person reports that's sensory in nature, the more physical stress that they also report, right? So again, there's when we often think about FOP, we think about the heterotopic ossification or the physical aspects of the disease. But I think it's just as important from a quality of life perspective to understand that there are these other aspects of the disease that are less visible, such as depression, such as pain, that I think really deserve to be on the front burner. We wanted to then, in these same patients, understand what's happening in their central nervous systems and how their central nervous system might be dysfunctioning, and how that dysfunction might relate to the amount of pain that they experience. So what we did was we actually set up shop at a FOP family meeting down in Orlando. And we had the opportunity to evaluate about 15 or 17 patients with FOP using a technique called functional near-infrared spectroscopy, or FNIRS. And basically what we did was we had patients come into a hotel room suite. We put a cap on the patients that's very similar to this. And we asked them to do something very simple. We said, just look at this white screen with this black cross. Stay as still as possible. Keep your eyes open. Try not to move too much. And let's just record what's happening in your brain. And the reason why we want to do that is because we just want to see how different parts of the brain are oscillating, how they're talking to how one part of the brain is talking to another part of the brain. And the region of the brain that we concentrated on was a region of the brain called the prefrontal cortex. Why did we focus on the prefrontal cortex? So the prefrontal cortex is really this area of the brain that controls so many different mental processes, whether it's working memory, cognition, emotional regulation, the decisions that we make, how we move, how we don't move. So And these are all different aspects that actually relate to pain. Say if you're in a very painful state, do you think that you're going to have very intact cognitive or memory capabilities? You're probably going to be a little bit distracted. Or if you're experiencing a lot of pain, I think it's, hopefully you can gather from the last few slides that I showed you that maybe you're not able to regulate your emotions as well, or you feel more emotional, or you feel more depressed. So that's one of the reasons why we concentrated on the prefrontal cortex and why we recorded our brain signals from this area of the brain. And so what we found was that those patients who report pain on a scale of 0 to 10 of 4 or more, we found that those patients had a little bit of a different pain signature compared to, sorry, this should be actually flipped around. They actually had suppressed activity. It should be, this pain to 0 to 3 should be actually in blue, and pain 0 to 4 should be in red. So apologies for that error. But what we found was that the high pain group, the 0 to 4 group, they had suppressed activity in the prefrontal cortex. And the more suppressed that activity in the prefrontal cortex, the more pain that was reported by patients. Okay, so this was one of the first findings to show that there's this central representation or this representation of pain within the central nervous system and in patients with FOP. And we also, of course, not only looked at the relationship between the function of the prefrontal cortex in the brain and clinical pain as reported by patients, but also their levels of depression. So you can see things go in a very similar direction. The more depressed the patients were, the lower the activity in that particular region of the brain. Any questions up until now?
We haven't had any come up in the chat, but this is very interesting. Thank you, Jaymin.
You bet, no problem. And so, with this in mind, I think, when you're thinking about pain treatment, this is maybe why, some of you found some of the discussions with my other colleagues from Boston Children's Hospital, like Eden, Randall, why maybe you're able to link up their perspectives on pain treatment and what we're showing you here. But, this is why when you think about pain treatment and FOP, it's not something that's just from the neck down that you should be thinking of or talking to your physician or your care provider about. It should be a whole entire whole body experience, right? Or whole body treatment approach, where you're not only looking at the physical aspects of pain, but how pain integrates with how you feel from a anger perspective, from frustration, from like, does your pain cause you anxiety? Does it give you a sense of helplessness or hopelessness? And those kinds of constructs should be incorporated in any kind of pain treatment approach. And there's, of course, a number of tools that folks like Eden and other folks at Boston Children's Hospital use to kind of address these issues, not only pain, but also associated emotional symptoms. And finally, I just want to wrap up and tell you a little bit about some of the other more recent activities that we've been doing in the lab. And some of it relates to pain, some of it relates to just understanding musculoskeletal pathology in FOP. So one thing we did was we started to utilize a technique called electrical impedance biography in order to tell us, well, what does this tell us not only about pain, but also muscle pathology in FOP. So, as many of you know, the way that muscle pathology or musculoskeletal pathology in FOP is monitored is with techniques such as PET-CT or MRI or what have you. These are, of course, very informative approaches, but they do involve things such as radiation. So you have a limit in terms of how frequently you can implement them. And so what we did was we started to use a technique, a non-invasive technique called electrical impedance myography to understand if the muscle structure in FOP is different compared to age-matched healthy controls. This is a very inexpensive mobile technique, and you're able to kind of get a whole body assessment of muscle health in about 30 to 60 minutes. We executed this study in the height of the coronavirus or the pandemic. And so, we weren't able to do things such as bring people to Boston or test them in our traditional clinical research or lab setting. So what we actually did was we sent this device as well as an iPad all across the country, and we evaluated patients everywhere from Maine to Washington, D.C., California, Florida. And we trained FOP patients, care providers, and their parents and their loved ones to use the device. And that's how we're able to kind of monitor muscle health in FOP patients. And so, we found that, there are different muscle properties in FOP patients, whether you look at it from a whole body perspective or from a more regional perspective, like the upper and lower body. And these changes that we see in muscle integrity integrate very nicely with the function or the physical capabilities in FOP patients. The other thing that we've been doing is, as I mentioned before, right now, the kind of standard way to assess muscle pathology or heterotopic ossification and what have you in FOP is to use techniques like PET-CT or just CT on its own. But we've been using a new technique that incorporates AI, a technique called synthetic CT or bone MRI to detect heterotopic ossification. So what we're able to do with this method called synthetic CT or bone MRI is identify regions of heterotopic ossification, get data that looks very similar to CT, but not expose the patient to any contrast agent or any radiation. So it's, I think, a safer way to monitor patients with FOP, but it does need a little bit of development and validation. So those are kind of what's next in line in our lab, in addition to understanding how we can better treat pain in FOP. So thank you very much for inviting my lab and me to present to the group today. And so I want to just thank so many people in my lab, as well as throughout Boston, as well as my older former colleagues at Regeneron for helping me get started in FOP and kind of continuing the research with this condition. So thank you.
Thank you, Jaymin. And I have a couple of questions. If people have other questions, feel free to put those in the chat. But before my questions, I wanted to point out that the EIM device, or is it IEM device?
EIM.
The portable one that you shared is also really a great tool, because what we see is that a lot of people with FOP, because of their mobility restrictions, actually have a hard time fitting into a CT or a PET scan. So having a device that allows them to still assess those things without that limitation coming into play is just incredible. So great work in identifying that and introducing it to the FOP community. And again, it's just so exciting to hear you share that those were caregivers or people with FOP at home during the height of COVID who were able to use that tool to participate in research. It's really a wonderful opportunity.
Thank you.
And then I had a question, but there's one that's just come in the chat about the study. So the question that just came in, I'll start with that and get to mine later, is following the study that you did, what do you believe could be the reason for people experiencing the moderate pain while others experience severe pain? Do you have any idea of what the factors that maybe came into play in those reported outcomes were?
So the pain scale, like that 0 to 10 scale, you have to kind of take it with a little bit of a grain of salt, right? Because my pain 5 on a scale of 0 to 10 might be different from, someone else's pain of 5, 0 to 10, right? So don't read too much about moderate to severe pain. That's why I just kind of leave it very broad. I think one thing that I would like to do in the future work is, and I think this is a little bit more relevant, is kind of move a little bit away from the pain scale, the 0 to 10 scale. It's important, but then incorporate how pain interferes in people's lives, right? Like if you are in pain, does that mean that you're not doing some certain activities that you normally do, right? I think that might be a little bit more informative than just saying that, okay, I experience pain of 5 or 6 or what have you. But at the end of the day, what gives someone the feeling that they are experiencing pain of 10 versus 4? It could be a lot of different factors. Maybe, it could be their mood that day. It could be, something physical that's happening with them within like their region of heterotopic ossification or what have you. So there's not a clear-cut answer to that.
And I'm sure when you get these results or this data, there's so many interesting things that you're like, I'd love to follow up on this. I'd love to learn more about that. So it's got to be hard picking your next project. But another question came in and this is a great question for everyone, I think, to understand a little bit better about research in academia and how it happens. So this question is about where these studies were done and does it cost anything to participate in them? So for the 2 different studies you've done, one was done in Orlando at the family gathering and the other was done virtually.
Mm-hmm.
And is there a cost to participants to participate?
No, there's never any cost. Your insurance is not billed. In fact, we provide the study subjects with study stipend. Those individuals who came to Boston to be part of the investigation or the study, we provided them with a travel stipend as well. So we try to do as much as possible to make it a low burden effort to be part of this work.
And that's sort of a good segue to one of my follow-up questions, which is that, first of all, Jaymin, it's such a phenomenal treat for us to have someone from academia presenting, because usually we have a lot of clinicians who are, providing care in a more clinical setting, but it's really wonderful to hear from your side of the contribution to FOP as well. And so I was wondering if you could share a little bit more about how you convey or share your findings with clinicians or with those who are practicing. Like what did you do with the information that you gathered? If you can talk about maybe articles or journals you published in.
Yeah, so well, I'll give you an example of what's been going on the last 2 weeks or so, right? So, I work at Boston Children's Hospital, and at Boston Children's Hospital, there is this center called the Pediatric Pain Rehabilitation Center, right? And not only do they treat patients that are pediatric patients, but they also have a young adult program. So what I did was I went to the director and the attending psychologist who spoke to IFOPA before. And I said, look, I have this population, right, that I've been working with, that I've been investigating, who have that have pain and it's not treated well. However, I feel that some of the kind of clinical strategies and approaches that you use in other patient populations and other patient populations that we are working on together right now on, you could use those same techniques to relieve pain in FOP patients. But I don't think the FOP community knows about these approaches, right? So how can we work together to take what I've learned from a research perspective and take what from a clinical pain treatment perspective and bring them together to lessen the pain in FOP patients on an individual subject basis.
Yeah, that's incredible. And that is the end goal, right? That research is done to help inform care and to help improve access for patients who are dealing with pain. So, ultimately the hope is that the biopsychosocial approach that's used at the Pediatric Pain Rehabilitation Center would be something that FOP medical experts would be, speaking to in their time with patients, or other that we could incorporate maybe into FOP treatment guidelines to help inform local healthcare practitioners, which is really exciting to think about. I know we get a lot of questions about, I've tried X, Y, and Z, sort of the pharmacological approaches, the most common ones, but now what do I do? So it would be great to have a resource to reference people to for that.
And I'm not saying that pharmacological approaches cannot be helpful in treating pain in general. They are for many people. But I think the kind of, what's becoming more and more apparent is that solely using pharmacological approaches might not have the same value as taking a more holistic approach.
Yeah. I agree. And that's part of the reason why we wanted to do this series, was to focus on sort of all of the different approaches that can be used together to help support people. So there was one more question that came in. This is wanting to know if your research, has it been done just for children and young people, or have you worked specifically? There were all ages in your.
Oh yeah, in all of so in the FOP registry, of course, we had 100 patients from I think young adults all the way to older adults. The brain imaging study that we did, I think there the age range was from 7 all the way to about 60, and a similar kind of age range for the patient for the EIM kind of virtual study. So yeah, we join. So we enroll everyone in our studies. From a pain treatment perspective, the work that we do there.
No,
the work that we do there, I think it's going to be, we try to implement certain types of pain treatment approaches in pediatric patients and other types in adult patients, just because when you're working with these two different age ranges, maybe what you do in children isn't applicable to what you do in adults and vice versa, right? Just because your experiences are different. Maybe in the child's case, you're involving a parent or a care provider a little bit more. So, it can vary from that perspective.
And that topic did come up actually in Eden's presentation, that there are more of those rehabilitation pain centers that tend to focus on the biopsychosocial approach for pediatrics than adults right now. So I know that was something she was really looking forward to working more on, is how can maybe adults have a little more access or information about this.
Right.
So great. Well, thank you so much again, Jaymin, for coming. If anyone has questions, I'm sure that Jaymin would be okay with me passing them along to him. So please, if there's something that comes up after today that we didn't get a chance to discuss, send it my way in an email and I will forward it on to Jaymin so we can get an answer back to you. But before we move on to focus on the pain management workbook, some additional content that I have to share, I just wanted again to say thank you so much for joining us today. To you, Jaymin, and your whole lab, who I know worked tirelessly on all of these studies to make them happen and to get your findings out and shared with the public. So
thank you for your support. Bye, everyone.